So guys, you can see my screen, right? I think you can. Okay. So the other day we were just talking about medical treatment and how it was different from like when we have a patient and we have a more global view of our patient, and not only how we can help with the medication, but also with some other specialties and some other health caregivers, such as physiotherapist or yeah, nutrition. And okay, someone just joined. Okay, so that would be the main difference, right? In medical treatment, we just focus or mostly focus on medication, drugs, and the usual stuff that you get to read in books. However, there are a lot of views that if you stop thinking about just medication, you can also help your patient, and the outcome of your patient's disease will be even better than if you would only take head of the medication, just medication, right? So we're going on to the surgical treatment. And what is surgical treatment? I'm sure all of you know, right? Because it's obvious. However, we have to follow what our infographics tells us, right? So surgical treatment is related to the use of operative manual and instrumental techniques on a person to investigate, treat, or treat a pathological condition. So what are some of the most common medical procedures? For example, one of the most common ones would be appendectomy, right? Does anybody know about the Murphy chronology? Especially senior students. I'm sure at least 2 or 3 of you like the surgical field. I'm more into the medical field, but I think I know that some of you might like this kind of diseases and how to treat them. So does anybody know what the Murphy's chronology is? Bernardo, you joined late, so you're going to answer. Okay, so what do you know about Murphy's chronology?
Hi, it's when you push the abdomen of the patient and he feels pain when you stop to push repeatedly.
Okay, that might be Murphy's sign, right? What about Murphy's chronology? In Spanish, cronología de Murphy for appendicitis.
I don't know.
Okay, what about Brisa?
Sorry, you mean like the three things together, like the symptoms, the signs, and the laboratory?
Murphy's chronology is just clinical. Okay, so their clinical findings not taking into account laboratories. Okay, just clinical. It's like when you have a patient who has this that has appendicitis, and it describes how this disease evolves during the time, or as the time goes by. How does it start? How does it continue? How does it end? That is Morpheus chronology. It describes how your patient is going to tell you if if let's imagine you are all doctors on your shift on the ER, right? And you have a patient and starts telling you about how he started feeling and how this symptoms developed during the time. That is Morpheus chronology, how the appendicitis evolves and how it relates to the symptoms and signs.
Oh yeah, so it starts like with pain in the epigastric and it goes to the mesogastrio or mesogastric, and then you can see too some nauseous and vomiting, and the pain just goes more continuous than on the start. You mean that? And maybe fever too. You can see that.
Okay, you're really, really close. Okay, as you just said, it starts at the epigastrium, right? You have diffuse pain actually. However, it could be if you ask your patient to point where he or she feels pain, he actually or she would actually touch all the abdomen. However, it could be at the beginning at the mesogastrium. Then, how does it evolve? What's the next step? It should be like the patient feels nauseated, nausea, right? And vomiting. And then, right after nausea and vomiting, the pain migrates into the lower right quadrant, right? And that would be it. Pain, non-defined pain. I mean, it is not very defined where it actually is because it could be the whole abdomen. Then the patient feels nausea and then starts throwing up, and then the pain goes into the lower right quadrant. That would be Morpheus chronology. However, there's one more thing that we should take into account. I remember when I read a book about surgery. It said that if the patient did not have anorexia, the appendicitis, the appendicitis diagnosis would not be likely to be the one. Okay, so there has to be anorexia. Okay, so it would be start. It would start with pain in the whole abdomen, mostly epigastric, right? Then nausea and vomiting and anorexia. And then right after that, the pain migrates into the lower right quadrant. Okay, that is Morpheus chronology. And here you have the Alvarado's score. Okay. Okay, so here you have Alvarado's score. Have you ever heard of it? Let's ask Danitza Burgoa. Have you ever heard about Alvarado's score? Danitza? Okay, guess she's not here. What about Danita Zambrana? Okay, what about Marcela Guzman?
No, I have never heard about that.
Okay, Mariana, maybe?
No, I have never heard about it.
And the last one, Paola?
No, I don't know. Hardly.
Okay, okay. So Alvarado's score is a score that helps us not to diagnose. That is the main point. It does not help us to diagnose appendicitis. However, it could help us define a possibility of appendicitis. It does not help us to diagnose because actually we have the certain diagnosis about appendicitis when we have the pathology report. Okay. However, this score helps us to determine if there is a possibility of appendicitis. And as higher as it gets, the more possibilities there are of the diagnosis, the correct diagnosis to be appendicitis. Okay, so when I told you about Morpheus chronology, we talked about some of the features in Alvarado's score. For example, migration of pain, right? It migrates, it starts at epigastrium or it is not actually defined where it is located, and it migrates into the lower right quadrant. Okay, anorexia, as I told you. I think well, I'm not that into the surgical specialties. However, I did like reading Schwartz, which is Schwartz surgery. And it said that if there was no anorexia in our patient, it wouldn't be likely to be appendicitis. So there has to be migration of pain, anorexia, nausea, tenderness in the right lower quadrant, rebound pain. Does anybody know what rebound pain is? Guys, I know that you must have read of it. Well, Danita Burgoa, are you here now? Okay.
Yes, I'm here.
Okay. Do you know what rebound pain is and what it represents?
Well, it's a pain after pressing on some point of the abdomen.
Okay, it's like when you stop pushing, it hurts more, right?
Yes.
Okay, and what?
After
Yes, great. After pressing, when you stop pressing, then it hurts more than when you press. And do you know what it means? What it represents? Rebound pain. You can say it in Spanish.
well, the sign it indicates peritonitis. There's a sign and that can help us. It's the Blumberg sign.
Great, awesome. In Spanish would be irritación peritoneal, right? Okay.
Yes.
Okay, elevated temperature, leukocytosis, and shift of the blood cell count to the left. In Spanish would be desvío a la izquierda, right? So the higher this Alvarez score gets when we have this patient, the more possibilities there are of it being an appendicitis, okay? So it just tells us about the possibility of appendicitis. Okay, here we have morphochronology. First, there is abdominal pain, nausea, vomiting, fever, and then the migration of the pain to the lower right quadrant. So before going to the OR, we have to stabilize our patient with hydration, getting rid of electrolyte abnormalities, pre-existing heart, lung, and kidney disease. And there's actually, this book tells us about antibiotics. A course of antibiotics before the surgery, it says it improves the outcome of the patient. So there are a lot of surgical treatments for appendicitis. We actually are more used to the open appendicectomy, right? However, there are some other features like laparoscopic appendicectomy, and this one is kind of weird. This is the natural orifice transluminal endoscopic surgery. And according to the letters at the beginning of each word, it is known as notes. Okay. The antibiotics as definite treatment, it says that we might not actually need we might not need surgery, and the only treatment would actually be antibiotics and the interval appendicectomy. Okay, so there are a lot of features in which surgical treatment combined with medical treatment with the use of antibiotics and interval appendicectomy could be related, right? Do you know any other disease that might be related to surgical treatment? Okay, Bernardo, what other disease could be related to surgical treatment? Bernardo, are you here?
Yes, but I don't remember. I am blue.
But
Oh, okay.
there are a lot of diseases that have surgical treatment. Just tell me one.
Yeah. Hmm. Ah, perdón, Doc, me bloqueé.
Okay, you're gonna get another chance later. And what about Brisa? Do you know of any other disease that might need surgical treatment?
Yes, could be a cholecystectomy.
Okay, great. And what do you know about this? Did you go to any of those surgeries? I mean, you're in Bolivia, right?
Yes, I am, but I've
Okay,
never went into a surgery. I didn't retake surgery yet.
okay, you didn't take it. Okay, this is actually the most common surgery here, at least in La Paz. I don't know what about Cochabamba. However, in La Paz, it is the most common one surgery. Okay, actually, here in La Paz, we have the highest index of patients with acute cholecystectomy or chronic acute cholecystitis and chronic cholecystitis, mainly chronic cholecystitis. Um, the epidemiology actually is as high as there's a tribe in Chile, which is the Mapuche. I don't know if you heard of it. They have the highest incidence of cholecystitis in the world, and we're close to it. So, as you might have realized, here in La Paz, we have a really, really high incidence of acute and chronic cholecystitis. Okay, what about Danitza Urigoa?
Another surgery, it could be hysterectomy.
Sorry?
Hysterectomy, I don't know.
Okay, the uterus, taking.
Hysterectomy.
Okay, great. And in what kind of diseases or in what kind of situations could this surgery be performed?
In uterus cancer, uterine cancer.
Okay.
I don't know.
Okay, you're great. Yes. Okay, that would be a great example. What about Danitza Zambrana?
Inguinal hernia. I don't know.
Hernia. Okay.
Hernia.
Okay. Inguinal. You remember the pronunciation? Inguinal hernia. Okay. Okay. Great. Do you know what an incarcerated hernia is?
Is when the puede ser en español.
Okay, but right after you're going to say it in English. You can do it in Spanish and then you can do it in English too, because this is an English course.
Es cuando la hernia no puede no puede llegar a volver a meterse al agujero porque ya está ahí atrapada.
Okay, and how would you explain it in English?
Okay, is when the hernia can go back to the hole.
Okay, it cannot be taken back into the abdominal cavity, right?
Yeah.
Okay. For you, all of you guys, you notice the pronunciation incarcerated. Okay, incarcerated hernia. Who's next? Marcela. Marcela, are you here? Okay, what about Mariana?
Well, I don't know if it counts in this topic, but it could be the replacement of a joint, maybe the hip.
Yes, great. Awesome. That is a good example. Do you know what? Well, I don't really remember. Do you remember the name of the surgery?
Well, I think it's total hip replacement.
Okay, and what about non-total hip replacement? Do you know what the difference is?
Not really.
Okay, and the total one, we also replace. Actually, we do not. Surgeons and orthopedics, right? Orthopedists replace the head of the femur and the neck, and also the cavity in the coxal bone. Okay, and in non total hip replacement, we do not take into account the coxal part, just the femur part. That is the difference. And do you know what it depends on? When do we have the total and the non-total hip replacement?
I don't know, but I think it's going to be related to how much damage is the whole joint in general.
Okay, actually, well, when we think about this surgery, we only have a fracture in the femur bone. There is no compromise at the coxal bone. Okay, in either case, total and non-total. And what does it depend on to replace also the coxal part? It depends on if there is arthrosis. Ok, si hay artrosis en la articulación coxofemoral, sí se realiza el reemplazo total de cadera. Si es que no hay artrosis, entonces se hace la subtotal o la no total, es decir, solo se reemplaza la parte femoral y no la del coxal. ¿Ok? Okay, what about now, Paola? You're the last one.
So I don't know the surgical treatment about appendicitis. Would you help me, please?
I mean, there are a lot of diseases that need surgical treatment.
Parkinson disease?
Yeah, that would require surgical treatment, not only medical treatment, but also surgical treatment mainly.
Would you say vesicula?
Okay, someone just gave that same example. Could you think of any other? I mean, the example was cholecystitis, right? What about some other disease besides appendicitis, cholecystitis, some replacement of a joint? Any other?
So I think that mucormycosis.
Sorry?
Mucormycosis. I don't know this how to pronounce this word. Mucormycosis.
I haven't heard of it. Could you tell me what this disease is about?
I don't know that. I know that CT scan of brain, sinus, and chest for stinging.
The fungal infection. That
Yeah.
one?
Yeah.
Oh, okay. Okay, it could be. Okay, thank you. So this part is actually really easy, right? I mean, we all know what surgical treatment is. So I think we're done with this one, and we will continue with, sorry. I'm going to do this really quick, okay? Okay, here, well, we're gonna with the screen and immunization topic. Here in Bolivia, we have this program, which is called Programa Ampliado de Inmunizaciones, right? PI. We all know it as PI. And there is a plan of vaccines that are related to a lot of infectious diseases, right? And since we have students from El Salvador, I searched for what it would be the same as the pie here in Bolivia, and this would be it. And I realized that in El Salvador, they always are taking into account the BPH, which is great. I mean, here in Bolivia, we're just getting started with it. Okay. So in Spanish would be vías de administración. Okay. However, in English would be routes of administration related to vaccines. So we have oral, intramuscular, subcutaneous, and intradermal administration. And there are these routes of administration are related to those the vaccines that you see beneath each one. Okay, and here you have the angle, for example, for intramuscular, subcutaneous, and intradermal routes of administration. Before we get started, we have to, well, if we had to talk about all the diseases listed here, it would take us a whole month, right? So I'm going to give you just a piece of what it actually represents about immunization. Okay, here, and before we get started, we have to know about immunology, a little bit about immunology. Here you can see a macrophage, which is ingesting bacteria, which is the Mycobacterium tuberculosis, right? So the red part is the cell, the macrophage, and the green bacteria is the Mycobacterium tuberculosis. Okay, so we're going to get started with actually, sorry, I missed some slides. Yeah, I missed some slides. Okay, before we get started, we're going to talk a little bit about the innate immunity. That is how we call it, okay? So actually, before we get to talk about the cells related to immunity, we have to talk about like the anatomical barriers to infection, to prevent infection. So there are like obvious components of innate immunity, and there are actually external barriers to microbial invasion, such as the epithelial layers and that have separate like the inner of the body and the external part of the external or the outside, right, from the pathogens of the exterior world. And these epithelial barriers include the skin, as you're just seeing on the screen, and the tissue and some surfaces of tissues that connect the bodies to the opening. For example, the mucous epithelial layers that line the respiratory, gastrointestinal, or genital tracts, and some ducts of secretory glands, for example, salivary, lacrimal, and mammary glands, which of course produce saliva, tears, and milk. And the skin and some other epithelium provide like a living plastic wrap, let's say, that encases and protects the inner of the body from infection. But these anatomical barriers are more than just like wraps or wrappers. They contribute to physical and mechanical processes that help the body shed from pathogens and also to generate active chemicals and some proteins as defenses by synthesizing and developing some molecules, including some peptides and proteins that have antimicrobial activity. So we might think as the skin has like a wrap that separates the inside from the outside, and that is not actually quite correct, because the skin produces some enzymes and some proteins that have antimicrobial action. For example, have you ever heard of psoriasin? Anybody, guys? Psoriasin, it is a protein. I'm going to start asking each one of you. Okay, Bernardo, it's your time to shine. The last time you didn't answer. Have you ever heard about psoriasin?
Yes, it's in the cell bloods, blood cells.
Psoriasin?
Yes.
Actually, it is on the surface of the skin, psoriasin.
Oh.
It is actually a protein that is produced by some skin cells, okay, that inhibit the growth of some specific pathological bacteria. In this case, psoriasin destroys or inhibits the growth of a very famous bacteria, which is Escherichia coli, or also known as E. coli. Okay, so for example, there was an experiment in which a person's fingers were inoculated with E. coli, and after 30 minutes, um, the scientists that developed this experiment were not able to find E. coli anymore because of the psoriasin. So this protein that is produced by some skin cells actually destroy E. coli. Okay, Escherichia coli. Okay, so that inhibits the growth of that bacteria, and that's why we're actually we get a lot of contact with that bacteria, and that's why we actually don't get sick that much with that bacteria because of the psoriasin. Okay, and there are some, of course, some mechanisms, some other mechanisms besides the skin. For example, and inside the mouth and the upper alimentary canal, there are enzymes and antimicrobial peptides that, do you know what SWEEP is, right? SWEEP. It's a verb. Do you know what it is? SWEEP. Brisa.
Deslizar.
Okay, you're close. Daritza Burgua, do you know what sweep is?
To sweep barrier.
Yes, barrer. Okay. Okay, so these enzymes and antimicrobial peptides actually get to destroy. However, there's a directional flow which helps the body to sweep the surface of by a directional flow of fluid toward the stomach. And you know, inside the stomach we have an acid environment, right? And it would destroy any kind of pathogen that was inside the mouth or the upper alimentary canal. And some other barriers such as the stomach, and there is low pH, digestive systems, bile salts, antimicrobial peptides, and fluid flow toward the intestine. And you know the difference, the pH is quite different from the stomach to the small intestine, which is the next step, right? And inside the small intestine, there are also digestive enzymes, antimicrobial peptides, and fluid flow that also like sweep any kind of pathogen down to the large intestine. And inside the large intestine, there are actually some normal intestinal flora, right? Some normal bacteria, and both compete with invading microbes. These invading microbes would actually be the pathogen ones, right? And there are actually some fluids and the feces expelled from the rectum, and some other protective innate mechanisms would be the airways and lungs, in which the cilia sweep mucus outward by coughing, sneezing, expel mucus, right? And inside the urogenital tract, there's flushing by urine. They get flushed by the urine and mucus. And there is also low pH antimicrobial peptides and some proteins. For example, that is the main explanation by which when we have a patient that has a urinary tract infection, we give our patient as a treatment C vitamin, which is not really that helpful, but in theory, it could help our patient to make the urine more acid and to have a more difficult environment for the bacteria to live in, right? And salivary and lacrimal and mammary glands, they get these pathogens get flushed by secretions and mucus and some antimicrobial peptides and proteins. So as I was telling you, there is a physical barrier, right? And the biggest one is actually the skin. And the skin, as I was telling you, produces an very big number of antimicrobial peptides that include psoriasin, as I told you, related to the inhibition of Escherichia coli. Okay, and what happens if this first barrier is broken? Some pathogens enter into the body, and then the innate immunity starts with the main cells. Can anybody tell me what, for example, can anybody tell me the innate immunity cells? What are the innate immunity cells? Okay, here you have the main cells related to innate immunity. Here we have the macrophage, the dendritic cells. When a pathogen enters, they develop a process which is called phagocytosis, right? In which they ingest the pathogen, and when they ingest the pathogen, they turn into a new kind of cell. Does anybody know how these new cells are called after the phagocytosis process? Does anybody know what these cells are called right after phagocytosis? This is physiology, guys. Come on. I know that you know. Okay, Danisa Zambrana.
The before after the phagocytosis, natural killer T cell had the phagocytosis.
Okay, we're talking about the cells that can develop the process of phagocytosis, which, for example, are the dendritic cells. So we're talking about the same cell, but it takes a new name. Do you know what name it is? right after phagocytosis. Hello. I'm sorry. Okay, there actually in Spanish would be células presentadoras de antígeno, right? Or in English, antigen presenting cells. Okay, so this cells ingest pathogens and they take one little part of the pathogen and join it with MHC molecule. Do you know what an MHC molecule is? Guys, come on. Okay. Okay. Marcela Guzman.
Excuse me, I didn't hear you at all.
Okay. Do you know what an MHC molecule is?
Not really.
Okay. What about Mariana?
I really don't know.
Okay. Paola, maybe?
Medicina alternativa.
Sorry?
MAC, right?
MHC. MHC.
Ah, um, I think that is in Spanish. I can say in Spanish.
Okay.
Complejo mayor de histocompatibilidad.
Great. So we have two main types of MHC molecules, right? Type 1 and type 2. So these dendritic cells that just ingested this pathogen puts this small piece of pathogen right, well, joined to an MHC molecule, and then this cell takes the name of antigen presenting cell, right? In Spanish, I'm going to say in Spanish. Entonces, un patógeno ingresa al cuerpo y los fagocitos, donde están los macrófagos y células dendríticas, por ejemplo, fagocitan al patógeno y toman una parte, o sea, lo destruyen, ¿no es cierto? Después vamos a ver el proceso de la fagocitosis. Pero toman una parte del patógeno, lo unen a una molécula de complejo mayor de histocompatibilidad y lo ponen en su superficie. Y ahí esa célula se denomina, a partir de ese momento, cuando pone en su superficie la molécula de complejo mayor de histocompatibilidad unida con la parte del patógeno que ha sido digerido en el interior de la célula, a partir de ese momento se denomina célula presentadora de antígeno porque presenta el antígeno a otras células, es decir, en la parte de la bacteria que ha sido destruida. And what cells does it present it to? I mean, the antigen. It presents it to the T cells, okay? And mainly to the T CD4 cells, right? And that is one small part. So what about some infected cells, such as in tuberculosis? Because you know tuberculosis, Mycobacterium tuberculosis is an intracellular bacteria, right? So how does the immune system destroy this kind of cell that is infected with tuberculosis? Then we have, well, here we have the NK cell, natural killer cell. It destroys the whole cell, including the pathogen. right? So there are a lot of pathways the innate immunity has. So here we have some tissue damage, right? And the bacteria cause resident sentinel cells, for example, dendritic cells, to release chemoattractants, chemoatrayentes, chemiotaxis, right? And vasoactive factors that trigger a local increase in blood flow and capillary permeability. You know, you must have read about inflammation, right? It's not a simple process. However, it takes into account a lot of molecules that are addition molecules. And here we have the addition molecules. And do you know what PRR molecules are? Okay. Danitza Burgoa, do you know what a PRR molecule is?
Sorry, I don't remember.
Okay. Actually, PRR molecules are a pattern recognition receptor. In Spanish, eh, receptores de reconocimiento de patrón. Okay. So those molecules that are on the surface of these cells can detect a lot of, let's say, for example, gram-negative bacteria, they all have in common that have one specific molecule, all the gram-negative bacteria, okay? So one of these, there are actually one main type of PRR molecules are the toll receptors. You must have read about toll receptors, los toll-like receptors. These toll-like receptors, there's, I think they have been described about 11 toll-like receptors, and each one can detect, can identify a certain pathogen or a specific molecule that is common to a certain group of pathogens. So for example, type 4 toll-like receptor detects and can identify just gram-negative bacteria. Some other toll-like receptor is able to identify gram-positive bacteria. Some other type of toll-like receptors can detect some types of virus, and that's how it goes. Okay, so this PRR molecules can identify specific parts of a group of pathogens that are not likely to change, because you know bacteria and viruses tend to change, to mutate and change the proteins on the surface of each pathogen, right? So this parts of the bacteria or virus are not likely to change. They're not likely to mutate. Okay, so as soon as there's this, there are these molecules, the immune system is going to identify these pathogens by the recognition of each specific toll-like receptor and some other types of PRR. So there are also some molecules on the surface. For example, here we have a neutrophil, right? And it starts rolling, the rolling process, and by diapetesis, it migrates into the tissue from the vessel. And then happens the phagocytosis. Here we have a graphic. Here we have a bacteria that binds to the PRR. You know what a PRR is, right? Now you do know. On the membrane, and there are evaginations called pseudopodia. Pseudopodia, these ones, right? Oh. Okay, these are the pseudopodia, and they wrap the, well, first the bacteria binds to the PRR, which are these ones. So the bacteria joins and binds to the PRR molecules, and then from around the membrane cell, the cell creates the pseudopodia to wrap the bacteria, and the bacteria gets ingested and forming a phagosome. This is the phagosome, okay? Then this phagosome joins with the lysosome. You know, the lysosomes are parts of the cell that have enzymes inside of them. So they both join, and the lysosomes pour their content into the phagosome and form the phagolysosome. So the pH change from alkalinic into an acid environment, and that helps to destroy the pathogen. The bacteria is killed and then digested by low pH activated lysosomal enzymes, as you can see here, because both lysosome and phagosome get together, and the enzymes that were inside the lysosome are now inside the phagolysosome, and this helps destroy bacteria. That is the phagocytosis process. And here we have an example, the BCH vaccine. These letters stand for Bacille Calmette Guerin. And when we're talking about the BCH vaccine, the route of administration is intradermal, and it prevents severe forms of tuberculosis. Could you tell me any severe forms of tuberculosis that the BCG vaccine protects from? Marcela Guzman.
I don't know if it helps in tuberculosis miliar.
Yes, that is one of them that it could help us with. Do you know of any other?
Honestly,
Sorry, Denisa, you were saying?
I don't know in English, but in Spanish is tuberculosis meningia.
Okay, meningeal tuberculosis. Great. So both are the most severe forms of tuberculosis, right? I've seen both during my residency. I've seen both tuberculosis in patients who had HIV infection. It is quite serious. One of those patients that I've seen with meningeal tuberculosis had a weight of 30 kilograms. She was really, really skinny, and she passed away, unfortunately. Okay, so this is a little bit about vaccine and how does it work. So here, as you read here, the route of administration is intradermal, right? So I already told you that beneath our skin, we have some sentinel cells, such as the dendritic cells. So here we have a dendritic cell. That is why the DC stands for, okay? So the bacteria gets ingested by the dendritic cell, right? And as I told you, it puts the one small part of the antigen with an MHC molecule and presents it as an antigen presenting cell, right? Presents it to a TCD4 positive T cell, joining through the T cell receptor. That is what this TCR stands for, T cell receptor. So the MHC together with the antigen gets presented to the T cell receptor, and then this T cell gets activated. This activated T cell, CD4 cell, produces this interferon, gamma interferon, and some other is how is it called? Tumor necrosis factor, right? In Spanish, factor de necrosis tumoral. So this cell releases these both cytokines, and these cytokines activate for example, here we have a neutrophil, right? And this neutrophil, what does it do? It could activate some other cells to increase the phagocytosis. And then we would have another pathway which is not also T cells, but CD8 positive. And when this T cell is activated, it forms, how are these proteins called? They're perforins. Perforins, as you know, they're proteins that get attached to an infected cell. In this case, for example, tuberculosis, right? We're talking about BCG. So let's suppose this cell is infected with tuberculosis. So the TCD8 cell produces these perforins that get attached to the infected cell and makes a lot of holes around the cell membrane, and then it ends at the process of apoptosis. This cell is destroyed along with the bacteria inside of the cell. So that is why we're talking about intracellular bacteria. You know, Mycobacterium tuberculosis is an intracellular bacteria, right? So this is the main process in which the T cells actually help destroy infected cells by the use of this perforins, these proteins, okay? So as I was telling you, the BCG vaccine, how does it work? This is another way this vaccine works. We already talked about the T cells, right? However, actually, this is the main pathway of the BCG vaccine, okay? However, there is also activation of the humoral immunity. Okay, so the humoral immunity is related to the B cell. When a B cell gets activated, it could take one of both pathways. It could be, do you know what these cells are called? How does the B cell differentiate into? Okay, what about Danita Zambrana?
Can you repeat the question, please?
Okay, yeah, sure. When a B cell gets activated, it could take one of two pathways, as you're seeing here. What are the names of those cells when a B cell is activated? You have one cell and the other cell. There are two pathways an activated B cell could take. Do you know the name of these cells?
No, I don't know.
Okay, Paula raised her hand. Okay,
I think
Paula.
that is B or T cells.
Sorry?
I think that is when B cells are activated. I think that this activity is the BCR to form microclusters and trigger downstream signaling cascades, right? cytokines produced by T cells,
Okay.
and other cells are important in determining what isotype the B cells express. I think I know that this concept, only just this concept.
Okay, so you told me that T cells, yes, they form some cytokines that could activate B cells, right? However, B cells could take one of both pathways. I'm going to say it in Spanish for you to understand, okay? Bueno, cualquiera sea la célula que haya fagocitado o también los polimorfos nucleares, especialmente neutrófilos, y también las células T, producen citocinas o citoquinas que van a activar a las células B. Y las células B, cuando se activan, pueden tomar uno de dos caminos, ¿sí? Cuando se activan las células B. Entonces pueden ser estas células que producen anticuerpos que se llaman células plasmáticas, ¿no es cierto? Las células plasmáticas, ¿cuál es la diferencia entre una célula plasmática y una célula B, o sea, un linfocito T que no está activado? Un linfocito, perdón, una célula plasmática aumenta su retículo endoplasmático rugoso. Y saben que el retículo endoplasmático rugoso sirve para la síntesis de proteínas, ¿no es cierto? Entonces, tiene más parte de su citoplasma, está ocupado por retículo endoplasmático rugoso, entonces esta célula está apta para producir proteínas, y un tipo de proteínas son las inmunoglobulinas, es decir, que las células plasmáticas producen los anticuerpos, ¿ok? Y el otro camino son las células B de memoria. ¿Cuál es la diferencia entre una célula plasmática y una célula B de memoria? Es que pero también produce anticuerpos, pero esta célula, la célula B de memoria, pone los anticuerpos en su superficie. Entonces la célula va por toda la sangre, va circulando por toda la sangre con inmunoglobulinas o anticuerpos en su superficie para que en el momento de que entre alguna bacteria que ha desencadenado todo este proceso de cascada de la inmunidad, en el momento que esta bacteria entre, ya esta célula se una directamente al receptor, bueno, a la inmunoglobulina que está en la superficie de la célula B de memoria. En cambio, la célula plasmática produce anticuerpos que van a estar circulando libres en la sangre. Sí, esa es la zona, es la diferencia. Entonces, cuando se activa una célula B de memoria, perdón, una célula B o linfocito B, se puede diferenciar en plasma cell, right, this one, and memory cell or B memory cell, okay? So how does the BCG vaccine work? It also activates the B cell, and it differentiates into the plasma cell, and the plasma cell produces IgG, or in Spanish, inmunoglobulina G. Y son varios tipos de inmunoglobulina G que produce esta célula plasmática activada. Entonces, los títulos de IgG se elevan cuando se produce, bueno, se inocula a un paciente con la BCG. Okay? I saw that in El Salvador, as well as in Bolivia, they applied this vaccine at the age of 1 month, right? And in some parts here in Bolivia, right after the baby is born, because we are in an endemic, this is an endemic infection here in Bolivia. So after 2 to 3 months, the cellular immunity is present. And how do we know the cellular immunity is present? Do you know the cellular immunity is related to the T cells, right? We can say it is present by the tuberculin test. Can anybody tell me what the tuberculin test is? Okay. Bernardo, it's your time to redeem yourself.
It's when we take the sputum.
Okay, nope. It is not actually. The sputum? No. Anybody else? Brisa, maybe?
The tuberculin skin test.
Yes. Also known as intradermal test, right?
I think it is when you inject tuberculin,
Yes.
and it's like the protect derivado. I don't know how to say that. El derivado proteico de la
Okay.
tuberculina,
Yes. Yes. Great.
and you put that on the arm,
The forearm, actually, right? The forearm and el antebrazo,
the
right?
forearm.
Okay.
Mhm.
And what happens if it's positive?
Um, I don't know. I think but what I know you is that you have to read the result in 48 hours, I think.
Yes, you have to wait some defined time. Yes. However, when do you say it is a positive test or negative test? It depends
It
on the,
depends on the. Oh, sorry.
yeah, you were saying you were going great. It depends on,
It depends of the inflammation of
the,
the how long it is.
it depends on the diameter, right?
Yes.
Okay. So what diameter are we talking about? When is it positive?
I think it's positive in more than 10 millimeters.
Okay, 1 centimeter, right? Yes, great.
Yeah.
However, is this useful in Bolivia?
I don't know. I've never heard about that.
Okay, it is not. Okay. It is not useful because in some moment of our lives, we're talking about an endemic infection, an endemic disease here in Bolivia, at least here in Bolivia. This tuberculin test does not work for us because it's like we all had tuberculosis by the vaccine, because we all get the vaccine when we are born, or when a person does get infected by the Mycobacterium tuberculosis. So it is not useful for us because we're all going to get positive results, and it is going to be like a false positive result. Okay, so it does not mean that we all had pulmonary tuberculosis. It means that we were exposed to some part of the bacteria, in this case, the vaccine. So it is not reliable here in Bolivia. I don't know if in Ecuador, in El Salvador, it is a reliable test. Can anybody tell me? Okay, senior students from El Salvador, can you tell me about the tuberculin test in your country, in El Salvador? Because I really don't know if it works or if it doesn't, like here in Bolivia. Okay, you're going to find out, okay? So when we have cellular immunity, and we can say it is positive when we have a positive result on the tuberculin test. So here we have some other infections that could be prevented with immunization. In Spanish is sarampion, right? In English would be measles, okay? In Spanish would be rubiola. Does anybody know how it would be called in English? Okay, you're going to find out, okay? In Spanish, we have paperas, right? In English, we have mumps. Okay. In Spanish, poliomyelitis. In English, poliomyelitis. Okay. Myelitis, poliomyelitis. Inflammation of nerves, right? Okay, someone just, yes, yes. Okay, Paula, rubella. Great. In Spanish, varicela. In English, chickenpox. Okay. In Spanish, tetanus. In English, tetanus. In Spanish, diphtheria. In English, diphtheria. In Spanish, coqueluche. English, whooping cough. Okay. So there are just a few examples of how these diseases are different in English and in Spanish. Okay, so that would be it, guys. There's a lot. I mean, we just talked a little bit about immunology. This is like the tip of the iceberg, right? Okay, so it's already 1.5 hours. Do you want to go on to the practice class, or do you want to leave it for Tuesday? It's up to you
Can
guys.
I leave it, please?
Sorry, who was speaking?
Can I leave it for Tuesday, please?
Okay, okay. We have one vote. Sorry, Paola, you were saying?
Yes, Tuesday, please.
Okay, we have two. Bernardo.
Tuesday, please.
Okay. Danitza Burgo, I want to know your opinion because you have some missing practice class.
It's okay for Tuesday, please.
For Tuesday?
Yes, please.
Okay. Yes, I think we had enough today, right? It's 1.5 hours almost. Okay, guys, so we're going to leave it here. We're going to call it a day. Don't leave before you complete the survey, please. I'm going to show it to you on your screens. Let me know so we can get this over with.
Done.
Okay, thank you guys. I think you're all done. Let me see. There are 3 questions, 6 and 6. Okay. Okay, guys, so we're done for today. Have a great weekend and I'll see you on Monday. And next week will be our last week. Okay, so we're going to start to say goodbye next week. Take care, enjoy your weekend, and see ya. Take care, guys.
Thank you. See you.
See you.